effects on the uterus, as well as what are treatment options that are available on the market. Many times the fibroids can cause us problems. This is a very common condition that we see patients in the office for. And so we are glad that you're here to learn more about the condition and your treatment options. So let's get started. What are fibroids? Fibroids are overgrowths. So it is overgrowth of the smooth muscles of the uterus and its fibrous connective tissue. It includes the smooth muscle of the cervix. Many times in the office, we will describe the uterus and the cervix as two separate organs, but they are indeed contiguous or they are connected. Above the internal os, which is here, if you can see my pointer, that is considered the uterus portion. And from the internal os to the outside of the cervix is or comprises the cervix. But all of that, the uterus and the cervix, are all made of smooth muscle. And so fibroids can grow off any aspect of the uterus or cervix or any other location of where smooth muscle lives in the body. They can range in size and location. In this picture that we have here, we have fibroids that could be part of the muscle, not impacting the surface of the uterus, not impacting the cavity where a baby would grow. And those are called intramural fibroids. You have fibroids that could be closer to the surface of the uterus than in the muscle itself. They're called subserosal fibroids, so just underneath the surface of the uterus. And then you have fibroids that can impact the cavity, causing an irregular contour of the cavity, and those are called submucosal. These often will give you problems with pain, bleeding, and definitely fibroids that are more subserosal and myometrial can give problems of bulking sensation or bulking feeling where your uterus, you feel more bloated because the uterus is enlarged. And sometimes, depending on how large they are, you can actually feel them through your abdomen. And that's what we're really trying to appreciate when we do an exam in the office and the bimanual exam. Fibroids can appear alone or in clusters. As we mentioned, they can grow into the uterine cavity. This picture actually doesn't show the fact that you can have a fibroid that is sitting directly into the uterine cavity, almost like an ear bob off of a stalk. Those can really cause a problem. And you can also have large ones that grow off the surface of the uterus, often described as pedunculated, that can give you that, that bloated discomfort as well. So all of the fibroids are made of overgrowth of the smooth muscle cells. And 99% of the fibroids are considered not cancerous. We don't really know the cause of fibroids, factors that can contribute to the development of fibroids, including multifactorial aspects. There has been research to suggest that they develop from an abnormal muscle tissue in the uterus, multiplies rapidly when encountering excessive estrogen that actually promotes tumor growth. The question is, where do we get excess estrogen? We can get excess estrogen from the foods that we eat or the foods of the animals and what they're exposed to. And as we consume those animal tissues through meat, beef, and other meat products, that can be an exposure. We develop or become exposed to excessive estrogen through our fatty tissues, because our bodies can convert other hormones into a weaker estrogen, but nonetheless a net gain of estrogen the more excessive tissue we have. So, but not everyone who has a BMI greater than 30, will have fibroids. We have women who are less than a BMI of 30 that still have fibroids. Sometimes we see them, or actually literature suggests that we also see them more frequently in women of color compared to other populations. In the United States, nearly 70% of Caucasian women and more than 80% of African American women will have uterine fibroids by the age of 50. It is estimated that 20 to 50% of these women will have fibroid experience, or with the fibroids will have symptoms, and those symptoms can include bleeding heavier than an average cycle. Some people will have a change in their cycle presentation, where when they were younger, they had normal flow, or a flow that really didn't impact their quality of life. And then you can, as you age or as you develop the fibroids, you can have excessive bleeding causing iron deficiency anemia. And again, you can have bulk symptoms where you're trying to work out and lose weight, thinking that, the lower bulge of your abdomen is a result of weight and fat, when actually it is a reflection of an enlarged uterus. Sometimes, depending on where fibroids are, they can cause pain, and they can also contribute to infertility. Each year in the US, more than 2 million women will undergo treatment for uterine fibroids. Oftentimes, we will see a fibroid history in the family, where maybe your mom had fibroids. Other women in the family may have had fibroids, contributing to a decision to have either the fibroids or the uterus removed.
And Dr. Whitfield, I believe Dr. Lane has joined us. So welcome, Dr. Lane. Thank you for coming on.
Wonderful. Thank you, Dr. Lane, for joining us. We let folks know that you would be here. I might have jumped ahead of the slides in terms of signs and symptoms. As I mentioned before, we can have some abnormal uterine bleeding, heavy and prolonged, potentially contributing to iron deficiency anemia. Sometimes we can have bleeding in between your periods, where you're bleeding more in a month than not bleeding. We actually consider in the discipline of OBGYN that a normal variation of your cycle can be every 21 to 35 days. Certainly, if you're bleeding more frequently than that or less frequently than every 35 days, things should be evaluated. You can also have, as I mentioned, the abdominal discomfort, the fullness. All of a sudden, your pants aren't fitting. Your abdominal girth is increasing, yet your weight is not. You can have pelvic pain, and that could be pelvic pain with movement, pelvic pain with intimacy, pelvic pain with shifting in the bed or with prolonged sitting or standing. You can have lower back pain. Definitely, if you have larger fibroids, your uterus is heavy, and definitely as your uterus grows, the weight of your uterus can push on your lower sacrum, your tailbone, and your lower back. You can have bladder symptoms as well, because your bladder, and I apologize, my Volt connection with work will go off during the presentation. But we will have, you can have bladder symptoms because the bladder sits in front of the uterus. And certainly as the uterus grows, it imposes on the space that the bladder can hold. and you end up having to go to the restroom more frequently or actually have difficulty in emptying your bladder. Think of a bowling ball or a gallon of water, or excuse me, a gallon of milk or something that you would put in a sink full of water. Definitely, as you put that gallon of milk in the sink, the water overflows, and that is a uterus displacing the space where urine could be in holding your bladder. So definitely, as your uterus grows, the bladder has decreased capacity to hold the urine that you would be able to hold otherwise. You can also have bowel symptoms, as we mentioned, constipation or excessive straining with bowel movements.
One question, Dr. Whitfield, that we hear often, does the size of the fibroid determine how severe your symptoms are? So the larger the fibroid, the worse the symptoms, or does it matter what size they are compared to what your symptoms are?
I would say that can contribute to your symptoms, but it also the location of the fibroid can contribute to your symptoms. So I would say size, but you could have a 3 centimeter size fibroid that's sitting in the uterine cavity that could potentially cause worse pain than a 3 centimeter fibroid sitting within the wall of the uterus or perhaps on the surface of the uterus.
Thank
So
you.
both can play a role in the symptoms that you have with the presence of fibroids.
Thank you.
Okay, you're welcome. What increases my risk for fibroids? As we mentioned, family history, we often see it in the family, and research has shown that there can be a familial component. Obesity, as I mentioned, we have 3 different types of estrogen that the body can form. Of course, the estrogen made by the ovary is the most potent type of estrogen, but we can develop a weaker estrogen in our fatty tissues that can add to the overall net increase in estrogen effect in the body. And we know that fibroids can grow with an environment with increased estrogen. So certainly working on can help with addressing the symptoms of fibroids. Having a diet high in red meat. Of course, you will find an article to support whatever you believe, but I have actually had patients to come in to the office and say, I really have tried to work hard and trying to read and identify ways that I can improve my bleeding and my pain. And I actually notice improvement of my symptoms, including flow, as well as pain associated with my cycles when I decrease my diet in red meat. This is a sidebar. I saw a presentation over the weekend about, it's a documentary called What the Health. I've been hearing about this documentation or documentary for a number of years. I strongly encourage that all in the audience take the time to view that documentary. It is now available on YouTube for free. It's about 1 hour and 30 minutes, but it talks about the food that we eat and the impact that it has not only on our bodies, including our gut flora, our cholesterol, our just the impact that the things that we eat can have on our body. So I learned a lot, and definitely there is literature out there to support that a diet high in red meat can certainly have an impact, because it's what we're feeding the animals that we consume that have an impact on the development potentially of fibroids or the symptoms that we have from the fibroids. And then risk factor of high blood pressure. We've seen that as a correlation.
And we do have a question in the chat. Is it likely that fibroids will shrink over time?
So Definitely, if there is a change in the amount of estrogen that we have in the body, we would expect the fibroids to shrink over time. A time in our life where we have decreased estrogen is when we're menopausal. So definitely when we're menopausal, that is a period of time where we have decreased estrogen. And as a result, we expect fibroids to shrink. But fibroids just don't go away. They don't just disappear, but they certainly can get smaller over time. So hopefully that answered the question. When is it time to do something about your fibroids? I would say if they are starting to affect your quality of life. If you're starting to, look for the nearest bathroom whenever you go out to a function because you're afraid you're going to flood your clothes, or you find yourself taking time off of work during your cycles because you are afraid of potential accidents. If you've had too many accidents to even describe, and you're just tired of being sick and tired, then I would say that would be a time to do something about your fibroids. When fibroids are impacting your quality of life, as I mentioned, if you're having some abnormal uterine bleeding, again, heavy, you're now having to use both pads and tampons, you're bleeding in between periods, you're developing iron deficiency anemia, and the anemia is then causing other medical conditions, it's time to have a conversation. A normal blood count level is 12.0. That's called the hemoglobin. Sometimes we see ladies walking around with a hemoglobin of 6, which is almost half of your normal size. And the question is why am I having a little shortness of breath? Or why am I having some chest discomfort? Or I can't really walk up the stairs like I used to because I really just get short of breath. Or I'm weak, or I'm tired, my energy levels are low. All of those are potential indications of iron deficiency anemia and should be evaluated. And remember that it's your heart's job to make sure that adequate blood and blood filled with oxygen is pumped to your organs. And if you don't have adequate blood flow to do that job, you can develop congestive heart failure, you can develop other medical conditions. I've seen patients where they've developed lower extremity blood clots because the uterus is so big, the pressure of that uterus is pushing on the main vessels that supply the lower legs for blood flow. And as a result, you develop vascular congestion below that fibroid, and increases your risk for blood clots. So, abdominal discomfort, fullness, your clothes aren't fitting anymore, pelvic pain, lower back pain, many of those signs and symptoms that we've already discussed. That's when it's time to intervene. Fibroid emergency. I think some of these things I just mentioned, if you're bleeding to the point where it is impacting your ability to function, you're having near syncopal episodes at work, you're passing out, you're sitting on I've had patients report sitting on the toilet and they became unresponsive, or you walking around with hemoglobins levels that would put you into congestive heart failure or potential heart attack. I would hope that you don't wait to that point. And many times patients, they don't really want to intervene until it's a crisis situation, but you really don't want to wait until that happens, because as I mentioned, if your main organs aren't getting adequate blood supply, you can develop heart failure, you can develop end organ damage. Severe pain, if you're doubled over, if you're spending more visits to the emergency room, your local you know, places where you stop in because you're having pain or you're dealing with iron deficiency, just treating those things are putting a Band-Aid over the symptoms, but it's not addressing the underlying issue.
Dr. Lane, I think
I
you.
wanted to just, yes, can you all hear me okay? I think
Yes.
my speaker wasn't on before.
Yes.
I wanted to really emphasize the importance of the quality of life piece. You know, every patient might be somewhat different as to whether or not their amount of bleeding impacts their quality of life. And you really have to answer that question for yourself. But if you find that you're bleeding so much that you're taking off work, or you're not doing things that you enjoy, or you definitely will not wear certain colors because you're concerned about your bleeding, then I think you can begin to start answering, is the amount of bleeding that I'm doing, even if it's the same amount you've been doing for the past 5-10 years, is my bleeding impacting my quality of life? And I think if you begin to start making those life adjustments, then I would say yes, it is. And hopefully you'll be able to answer that question before you get to the emergencies that Dr. Whitfield discussed. And if it's okay, Dr. Whitfield, I'll jump in here and I'll kind of I'll move on with the presentation from this point, and you can feel free to take the slides on. So now
Dr.
that we
Lane,
know how.
I have 2 questions in the chat if you would like.
Sure.
Okay.
Sure, go ahead.
So one is, can fibroids cause swelling in the legs?
Well, I think that gets to part of what Dr. Whitfield was referring to. It depends on the size of the fibroid and where the fibroid is located. It's very possible that you can get what is called bulk symptoms from fibroids, and that really refers to that size of fibroid, that location of the fibroid, where it's located. It might be compressing on something, and in some cases it's a large blood vessel that's carrying blood from your legs, for example, all the way back up to your heart and your brain. So it is possible for you to have swelling in certain areas. You can have bulk symptoms where it's compressing on your bladder, and maybe your bladder is not filling as well as it should. Maybe you're compressing, maybe the fibroid is compressing on the colon, and you're dealing with chronic constipation. So a lot of these symptoms can be directly connected to the size of that fibroid and where that fibroid is located, and sometimes even how many of them are located in certain areas of the uterus.
Thank you. And then one other question in the chat. I do not drink, smoke, eat beef or pork, no heavy periods, labs normal, and still developed a fibroid the size of a baby's head. Is it likely that it was just hereditary that she developed them?
I would probably say most likely it probably is. And we're not always going to know why one person develops fibroids and another person doesn't, but there is that familial component to it. And I would just say, keep up the good work with your lifestyle and what you're doing, because that actually might be preventing growth of your fibroids. So, but yeah, it very well could just be a genetic component to it.
Thank you.
All right, well, we'll continue on with our presentation. Dr. Whitfield did an excellent job reviewing risk and signs and symptoms. And now it's important to start thinking about, okay, well, how do I know if I have fibroids? And there are some imaging studies that your doctor can order in order to know. But the first step is often the physical exam. So the history in the physical exam, hearing what your problem is, listening to your concerns, what you've been dealing with, that's going to raise our suspicion. And then also the physical exam. What does your uterus feel like? Many of you have probably had what's called a bimanual exam, and that's where we insert 2 fingers into the vagina and we have one on top of your abdomen. And what we're doing is we're feeling the uterus, how big it is. Does it seem to have any lumps, any bumps? We're also feeling the ovaries on either side. We get a lot of information from that exam. So that's probably the first step. And then the second step is to start thinking about imaging studies. One of the most common imaging studies that we do is the pelvic ultrasound. And the pelvic ultrasound can be done in the office. It can be done in the radiology department at the hospital. We often will either look transabdominally, which means we're rubbing the probe on top of the abdomen, or what my favorite is to look transvaginally. Transvaginally is a long probe that goes into the vagina, and it allows us to see a greater detail in many cases of the uterus and the ovaries. Now, if you have a large uterus, the combination of the two is very helpful, because sometimes with transvaginal ultrasound, we may not see the entire uterus, like the very top. So it's nice to kind of go back and forth. So if you need an ultrasound, a complete ultrasound with both transabdominal and transvaginal is something that I often like to order as well. And then MRI. MRI is another type of imaging that is becoming, I would say, probably more common in gynecology as we are diagnosing more fibroids and managing and treating more fibroids. Very helpful in terms of identifying number of fibroids, location of fibroids, vascularity to fibroids. So also a very helpful study. There's another test called a hysterosalpingogram. And this is a test that's done often by a radiologist. It could also be done by your gynecologist as well, but it's done in the radiology department. And what happens typically is that you are in stirrups, like a pelvic exam, very similar, and dye is pushed into your uterus, and that dye will fill the cavity of the uterus. It also will let us know. Sometimes we do this test often with fertility as well, to determine if the fallopian tubes are open or not. But it would be helpful in the case of a fibroid, of identifying a fibroid that might be within the uterine cavity. So that's a test that could be done. The sonohysterogram, or sometimes it's referred to as saline infused sonography, is a test that's done in the office as well. It's using transvaginal ultrasound, but at the same time, what we do is we infuse fluid into your uterine cavity. So instead of your uterus being flat, it starts to open up almost like a water balloon, and it allows us to see the inside of the cavity. I actually love saline infused sonography because it really gives us a lot of great information about that uterine cavity. Are there any masses, polyps, fibroids that are in that cavity that could be contributing to your bleeding? And then another very common surgery to do is called hysteroscopy. And hysteroscopy is a day surgery procedure. It's all vaginal. There's no incisions on your belly whatsoever. Also a wonderful, wonderful technology to evaluate the uterine cavity. And it's great for those fibroids that are inside the uterine cavity. It also is great for doing biopsies. Maybe someone couldn't tolerate a biopsy in the office, or maybe their biopsy wasn't sufficient. It allows us an opportunity to do a more thorough biopsy of the tissue on the inside. And then if you have things like polyps, fibroids, we can actually remove them using hysteroscopy. I often will combine hysteroscopy with other surgical techniques as we talk about different surgical techniques. So that's how fibroids are diagnosed: history, physical exam, and then imaging studies. So let's start talking about, how do we manage fibroids? There are a variety of options. Now in this generation, we're excited to tell you that there are a number of options way beyond what our grandmothers and our mothers had. So I'm just excited, so excited about that we've made that advance. But the first thing is you could do nothing and just observe them. Just because you have a fibroid, it does not mean that you need to run and have surgery. You need to go and do a hysterectomy or any kind of procedure. If you just notice, hey, you have one or two fibroids, they're small, they're not causing you any problems, that's something. You're not having heavy periods, absolutely no symptoms whatsoever. That might be someone that says, you know what, I'll just watch these, I'll monitor these, and that's perfectly reasonable to do nothing and just observe. Then we get into the variety of options that we have now. Medical management. There's also the use of surgical management, including minimally invasive procedures such as the use of hysteroscopy, like I discussed before, and going in and actually removing a fibroid. That's called hysteroscopic myomectomy. There's also the option of uterine artery embolization. That is a procedure done by an interventional radiologist. And what they do is they actually stop the blood flow to each of the fibroids. And the goal is to shrink the fibroid and then lessen the amount of bleeding that you're having from that fibroid. And then you can also have laparoscopic surgery where you can actually, or an open surgery to actually remove the fibroids. These are what we call more invasive procedures, and they have a longer recovery time. And but definitely something for some patients that may be the best option for them. And then there's also hysterectomy as well. But there's one procedure that that we love, that really we want to talk to you about today, called the transcervical fibroid ablation, transcervical fibroid ablation. And it is also, the brand name is called Sonata. So we are really excited about that technology, and we'll be talking about that technology just a little bit later. But let's start focusing first on the medical management. There's a couple of different medications that could be used. I probably say, just for the sake of time and simplicity, I'd probably say some of the more common are hormonal contraceptives, such as using pills, the patch, and the ring. Also progesterone containing agents. So birth control pills or many hormonal contraceptive have both estrogen and progesterone. And sometimes we might use something that has a pill with estrogen and progesterone. In some cases, we might choose something with just progesterone. And the choice really depends on the particular patient, the history. There may be a number of factors, maybe their medical history, that may drive us to choose one option or another. But at least if you take a screenshot of this, you can talk to your doctor and say, hey, is this something that's an option for me? Progesterone agents, probably the more common is something like an IUD. We use that for contraception, but it's a great option for controlling bleeding. It is, however, difficult to use if you have a large mass inside your uterus, like a fibroid. And that's where a surgical intervention might come into play first, and then you might say, okay, now I think I'll try the IUD. So you can kind of mix and match some of these options. And then there's a medication called Orion, which is available. And by month 1, it can decrease your bleeding by about 50%. But you also have to use birth control with this option as well. And you cannot take this medication for longer than 24 months. And the last statement I'll say on this slide is the concept is the very first one, the GnRH agonist. This is a medication that really, it quiets the ovaries. It really puts you almost in a state of menopause, so that then those fibroids will start to shrink. But it also is not a medication that you want to use for a long period of time.
And Dr. Lane, we do have a few questions. One is, what is the recovery time for a hysteroscopic myomectomy, specifically for fertility?
Oh, that's a great question. The recovery is actually really, really quick. I would say a procedure like that you probably, let's say you had it on a Friday, by 24 hours, you'll be feeling great. You might just have a little bit of cramping. By Monday, you'll be definitely back to work. So at most, light cramping on a hysteroscopic myomectomy. When you start getting to the laparoscopic or open, that's when the myomectomies have that procedure has a longer recovery time. A hysteroscopy doesn't. We're talking within a day, you'll be back to normal pretty much.
Thank you. And then another question, whenever you are on medical management, does it stop your fibroid from growing or just stop or help with the symptoms?
It's more what I would say is, and Dr. Whitfield, feel free to jump in. What I would say is it really is more of a symptom control, and really managing your bleeding and trying to get your bleeding under control. When you start thinking about shrinking the fibroids with medication, you're really looking at something like a GnRH agonist. That's what I often think about when I'm trying to shrink a fibroid with medication.
And as Dr. Lane mentioned, some of these medicines that work to shrink them, you cannot take them indefinitely. There is a limited period of time because you have to think about the benefits of estrogen. And as she mentioned, if the GnRH agonists are putting you in such a quiet state of ovarian function, similar to symptoms of menopause, then the benefits of your estrogen levels are also decreased. Some of the benefits of estrogen is protecting your bones, vaginal lubrication. Sometimes a decrease in estrogen can have an impact on your mood, on your sleep patterns. And so we often will use GnRH agonists to shrink the fibroids so that we're preparing for uterine sparing surgical procedures and for patients who are looking to preserve their uterus in order to carry children. So one can be on the GnRH agonist for a maximum of 2 years, but the moment that you come off of that medicine, your fibroids can grow back. So the goal of those meds, imagine that someone is walking around 9 months pregnant and it's their uterus with no pregnancy inside. That's pretty impressive. And you can imagine what type of incision that you need to make on that uterus, even if your efforts are to try to remove the fibroids. That is putting, taking a lot of purchase out of the volume of the uterus. And if the goal is to carry a pregnancy, we want to be able to preserve as much functional tissue in order to meet our end goal, which is to become pregnant and to have a baby. So GnRH agonists help to shrink the fibroids in preparation for surgical intervention, but the goal to keep our uterus. And sometimes we will do that in preparation for a hysterectomy also, to minimize the size of incision, and the greater the incision, the potential increase in the length of recovery time. But a lot of times the hormonal options are to treat your symptoms, especially if you're not ready for surgical intervention.
And something to keep in mind is that when you use GnRH agonists, it takes some time to shrink that fibroid. Even when we use it prior to hysterectomy, it's not like an immediate fix. It takes some time. And oftentimes, I'd say it could take even up to 6 months to get the optimal shrinkage. So for many women who are having bleeding from their fibroids, they just don't want to wait 6 more months. I mean, it's like, that's just a process. And so, and then you kind of just weigh the risk and benefit of waiting that time, becoming more anemic, missing more work versus just going ahead and having some type of treatment. So everything kind of has its pros and its cons. So, yeah. The next slide, I pretty much touched on in terms of surgical options. So I don't think we need to go through all these details again. The only one I didn't mention is the Acessa, and that's actually a laparoscopic approach to treating fibroids. Probably an easy way to say it is you have the laparoscopic, really tiny, small incisions, and they're able to go in and literally zap each of the fibroids, but it does require an incision on the belly, which often is a little bit longer recovery time than some of the procedures like a hysteroscopic myomectomy or fibroid resection. That doesn't require any incisions. And I'm going to allow Dr. Whitfield to take back over and tell you all about the exciting procedure called the Sonata that does not involve any incisions on your abdomen, and the recovery time is so much faster than those more invasive procedures. Dr. Whitfield, take it away.
Thank you. So, as we mentioned, the formal term of the transcervical approach to treating fibroids is called Sonata, and the procedure is now available in the US. It's been available abroad for a number of years. The benefit of the Sonata is, again, that it is transcervical. So that means we're placing you in stirrups, we're putting you in the position to advance the instrument through the cervix and into the uterine cavity. So there are no incisions on your belly. It preserves the uterus and does not involve removal of tissue. So we're not actually going in and resecting fibroids. We are treating the fibroids with radiofrequency, which has an impact on the proteins that the fibroid is made up of. And as a result, the blood supply to the fibroids are affected, as well as the volume of the fibroids. And sometimes, depending on the services that you have available in your office, it can be performed without general anesthesia or an overnight hospital stay. It is important, if there is an option to do it in the office, to have some, I would say, an anesthesiologist or a nurse anesthetist available to be there to help to control your pain. But sometimes there can be medicines that we can place vaginally, inject cervically, to be able to perform the procedure without general anesthesia. What the procedure actually involves is passing the wand, again, through the cervix into the uterine cavity. The wand actually has ultrasound capability. So the ultrasounds that we do on the abdomen, we're actually able to see real time within the uterine cavity, because there is a viewing or an ultrasound portion of the wand at the end of the tip. So during the procedure, we're actually performing real-time ultrasound and evaluating where the fibroid is, the size of the fibroid, and assessing how and to what degree we're going to apply the radiofrequency. The handpiece delivers the radiofrequency energy to treat the fibroid through prongs that are expressed once we've gone through the safety steps. And the timing also is noted on the procedure real time and on the screen. And the wonderful thing is there are a number of safety mechanisms in place to make sure that we are providing the appropriate amount of radiofrequency without significant spread to the normal tissues. The handpiece can be repositioned to treat additional fibroids. So this is not a procedure limited to the treatment of one. It really depends on how many fibroids you have, the size of the fibroids. And remember, this procedure is to address predominantly the fibroids that impact the cavity, as well as the bulk symptoms associated with fibroids within the muscle of the uterus. This is not a procedure for fibroids that are subserosal, as we described before, that sit close to the surface of the uterus, or the pedunculated ones that are on top of the uterus, because we do express a degree of heat during this process. And if we are trying to reach to address the fibroids that are on the surface, that heat could be transferred to the surrounding organs, which can include the bowel. So again, this procedure is for fibroids that impact the cavity, submucosal, within the myometrium, but there is a safety zone that we stay within to avoid any potential damage of the normal tissue surrounding that fibroid or any tissues that are on the outside of the uterus. The fibroids do shrink over time, reducing and eliminating your symptoms.
Dr. Whitfield, I just wanted to add
Sure.
that safety piece is just so important, and I think the Sonata technology, they've done such a wonderful job trying to ensure that it is a safe procedure for patients. And with that said, your gynecologic surgeon also has to use judgment as to whether or not certain fibroids are going to be appropriate for the procedure. It might be that you may have, I'll just throw out a number, like 5 fibroids in your uterus, but maybe only 3 of them are meeting criteria for treatment, because maybe one is too close, that subserosal, like Dr. Whitfield referred to, or maybe one is actually on the outside hanging off the edge. So the ones that are closer in the uterus, maybe even closer to that uterine lining, actually those are probably the ones more likely to be causing your bleeding symptoms anyway. So it's kind of like a judgment call with your gynecologic surgeon, but then also there's that built-in technology to make you feel reassured that this truly is a safe procedure.
Okay. More than 5,000 women have been treated worldwide with the Sonata, and there are over 40 articles that are published in medical journals that concluded that the Sonata is safe and effective for treating symptomatic uterine fibroids. And this is a wonderful procedure when you're trying to preserve the ability to become pregnant. Because we are addressing the fibroid, and there has been studies to show that women have gotten pregnant after having this procedure, and there has been no placental dysfunction. So as OBGYNs, we're concerned about the integrity of the uterus, and should you become pregnant, will that placenta that feeds and nurtures the pregnancy and the baby, will that placenta work well to yield us a healthy baby? We want to try to avoid procedures that are going to increase risk of the placenta growing through the uterine muscle, making it a very high-risk procedure, and potentially increasing your risk of a hysterectomy after that delivery. And the current study in the literature suggests that there is no, or there has not been any reported incidences where you've had abnormal, what we call placentation, or problems getting pregnant and yielding a subpar, pregnancy or outcome because of the procedure. So that is a game changer, I believe, in our treatment options. That is an option was not available when our parents were growing up. Oftentimes the option was a hysterectomy. If you're done with children, you're tired of bleeding, just take it out. And so that's why we probably hear more from our parents that, I had fibroids and I had a hysterectomy, and so perhaps that would be the best option for you. You can now tell your loved ones that there is such an advancement in technology where you don't always have to have your uterus out. And you can have them treated and still keep all of your women parts. Sonata, in the Sonata trial, there were 147 women who were treated and followed over a 3-year period. And what they found was 50% of those women returned to normal activity the next day. So that means someone asked about recovery time. It really depends on the patient. It really depends on their pain tolerance. But there have been some who were treated and returned to normal activity the next day. Now, because we do dilate your cervix and we are placing a device in the uterine cavity, oftentimes our recommendation is that you not engage in intimacy, not engage in activities where you're being completely submerged in water, like a pool, like a creek. You're going on vacation and you're in a hot tub. Now, that is part of normal activity, but we do send you home with some restrictions because we want to decrease your chances of developing an inflammation of the uterine cavity, and you want to allow that cervix to contract back down and close, minimizing that risk of potential infection. So normal activity doesn't mean all activity, but certainly you can return to work, limiting the time off that many people have with the bleeding and the pain with symptomatic fibroids. With this study also, you had 95% of women had reduction of their menstrual bleeding at 12 months, 95%. So that is an impressive finding because many times that is the main complaint of fibroids. I'm bleeding and I'm in pain. So that is an impressive find. 94% were satisfied with the treatment received in 3 years, and 88% of those folks also, and I have my little slide covered up here. Just one second.
They reported improved symptoms.
Thank you. Thank you.
Mm-hmm.
Wanted to make sure I saw that.
And a question.
This video.
Oh, I'm
I
sorry.
was going to say this video does not have sound, and it's really meant to talk over it and explain what we're seeing if you do show the video.
Okay. And I'll let you take back over on this component.
Okay.
And
Alrighty. Are you able to? Oh, go ahead, Tara.
one question is, how long after having Sonata do you start to see relief from your symptoms?
So
I usually tell.
Go ahead.
I was going to say I usually tell patients that it can take up to 3 to 4 months for them to see a change in their menstrual bleeding, but it could potentially take longer. So I would just be patient throughout that first year after the surgery, but it may be a good 3 to 4 months before you notice a difference. And so just know that, and if it works for you, and it's going to be great. It's just about being patient.
And we want you to have reliable expectations. I mean, if you've been bleeding, a 7-day, 10-day cycle, we want you to realize that perhaps, with your next cycle, it's only lasting 5 days, or you are passing liver-sized clots where you're no longer passing clots anymore. That is certainly an improvement that you can see as early as the next cycle. I actually performed a Sonata on a recent patient, and she came into the procedure on day 3 of her cycle, where day 2 and 3 are her heaviest. And within that 24-hour period of her cycle, when I called the following day to see how she was doing, she was like, oh my gosh, I was just shocked. I have very little bleeding on my pad, and I just had the procedure yesterday. So I think it really depends on the patient, on the fibroid that we treated, the location of where it was. All of those play a role in what your symptom outcomes will be. And if your biggest concern is bulk, then it's possible that it's going to take more time for you to notice that your uterus is not as heavy. But in terms of bleeding, you could see a change in your bleeding, within that next cycle.
Yeah, and I would just echoing that, I would just say, try to identify for yourself before surgery, what does success mean? Does success mean that my fibroids are smaller? Or does success mean that my bleeding is less? Or does success mean that I don't have any bleeding whatsoever? And I think that gets to that management of the expectations after surgery, because then you can start kind of gauging whether or not you really had benefit from the procedure. I think we're optimistic that you will. So, Dr. Whitfield, if you're able to put this back in presentation view, and let's see.
Slideshow.
Mm-hmm. And there's a little play just on the screen over to your left, right there. Yep, just press play and it should play. It's not playing for you? Let's see here.
Let's see. Let's try it one more time.
Okay.
Mm-mm.
Does our Sonata team have the Sonata video by any chance? If not, I can share my screen and show it.
I can find it, but it may take me a moment.
So I
Okay,
will,
let's see.
I'll stop sharing my screen.
Okay, all right.
And we do have a
Let's
question,
see if I can.
the video, which is how soon do patients resume physical exercise?
So
I would say, oh, go ahead. I would just say you really could resume physical if you feel good within, I'd say definitely within 2 weeks. Everyone's recovery can be a little bit different in terms of pain tolerance and are they cramping a lot or not. So I would just anticipate at least 2 weeks you should be feeling pretty good. Okay, let's see here. Are you all seeing my screen?
we are.
Yes.
Okay, all right, great. All right, once again, this doesn't have sound. We'll just kind of talk through it. And it takes a little moment for it to load. So once again, it's a transcervical fibroid ablation system, and that's Sonata. And if you Google it, if you Google keyword Sonata and uterine fibroids, it'll come right up. And it's incisionless, it's transcervical, meaning it goes it's through the vagina to the cervix. And this is how you're positioned literally on the exam table that's showing 2 pads to prevent you from getting electrical energy into your body. And this is just showing an example of a uterus with the fibroid, and the device will be inserted through the cervix into the uterus, releasing a radio frequency energy. And once again, is what happens is that device is going to be pretty much laid right against that fibroid. And in the bottom right-hand corner, you can see an ultrasound image. That's actually what we see when we're doing the surgery. And we get a nice position, making sure we're going to send that energy beam exactly where we want to send it through that fibroid. Now, these are those little safety zones that we talked about. We anything inside the green basically is we definitely don't want to go outside that green area for sure. And then this is the probe that gets inserted into the fibroid. And we're doing some safety checks to make sure we have a good positioning in the fibroid. And then we're going to release some prongs, is really what it looks like. And we do another safety check to make sure that we are in the fibroid and secure and in position. And then once we've met the safety criteria, we start zapping away with the energy. And then as you can see, that fibroid turns a color whitish, that whitish color, showing us that that fibroid is dying because of that energy that we applied to it. And then we just basically, and what we can do is actually take that device, reposition it, direct it to the right or the left, and treat another fibroid. So that's kind of how it is. And I think this calendar might be showing us that ablated fibroids will shrink over time. And I think that was showing us about a 3-month period of time. And oh my goodness, in that animation, you could see that that fibroid was actually gone. I think that's really cool. So kudos to Gynesonics and the Sonata procedure. It's just an exciting procedure. I enjoy talking about it, sharing it with you all. It's just awesome. These videos are also available on YouTube, so you all can look at those, and you can probably even find the one with sound as well. And it's awesome. I think we have another slide after this. Let's see here. So if you're sitting and you're thinking like, man, what do I do? I have these fibroids. The time really is now to begin investigating your options. You don't want to wait till your hemoglobin is 5. Remember, Dr. Whitfield talked about a normal hemoglobin is 12. So you don't want to wait till your hemoglobin is 5. You're barely making it every day because you're so tired. You're missing work all the time. You're about to get terminated because you're missing so much work. You're staining your clothes. You know, all these things that are affecting and impacting your quality of life. You really don't have to sit at home and suffer. You actually can make a decision now and begin to start investigating your options. And it's important to know that women waited an average of 3.6 years, with 32% of waiting more than 5 years before they began to investigate their options. And 79% of women say they don't want invasive surgery. I mean, how many of you, either yourself or your friends or your family members, have been told immediately, hysterectomy, that's what you need? And 79% of women say they don't want an invasive surgery. Hey, I'm busy. I got a family. I got to work. I got to get back to my life. You want something that does not have a long recovery time. And as we were discussing earlier in regards to fertility, women want to preserve their uterus, even in cases if they don't want more children. So that's just some little tidbits for you there. And then just some contact information. Feel free to screenshot this information. You see Dr. Whitfield Kakesi's information. She's over at the TriHealth Women's Center Kenwood and TriHealth Women's Services Global Partners in OBGYN Rookwood. And then I'm located over at TriHealth Women's Services Finneytown. And this is our contact information. We really hope to hear from you all. We don't want you to suffer anymore with these fibroid symptoms. It is time now to begin investigating your options. And these are some of the resources that we use. You're welcome to screenshot that information well. And then I'm going to stop sharing in case you all have more questions for us.
Thank you both very much. This was very informative, and you make it fun to learn about fibroids and your treatment options, including Sonata. We do have a question in the chat, which is, what aftercare is required to prevent fibroids from returning after the treatment?
You know, that's a really, really good question. And you may not be able to control a fibroid from returning. It also may be that fibroid shrunk, it went away in a sense, or it's not detectable, but maybe now you had another fibroid that wasn't detectable earlier, but now you see it. So it makes you feel like it came back, but it really could be really another fibroid. I think some of those lifestyle things that we talked about earlier can be helpful, making sure that you have even like a Mediterranean diet, reducing your red meat. You want to reduce your weight and decrease the chance that you're heading towards obesity. I would say even there's some studies out there about vitamin D and supplementing with vitamin D, because that has been shown also to reduce fibroid size as well. Dr. Whitfield, what would you say? Anything else?
Nope. I would say that the fibroids that we treat don't necessarily come back, but it is common, depending on the time frame between your treatment and potentially going into menopause, that you can develop new fibroids. So depending on the size of the fibroid, as the video showed, we can treat several angles to try to make sure that we are treating, at least 70% of that fibroid. And we may have to apply that radio frequency in 2 or 3 different angles, again, depending on the size. So it's not necessarily the thought that that particular fibroid grew back. It is possible for you to develop new fibroids or it may, as we mentioned before, we are there to treat the fibroids that are giving you the most symptoms. A 1 or 2 centimeter fibroid sitting in the middle of the uterus is not necessarily contributing to bulk or bleeding. However, over time, that particular fibroid could grow, and we know that estrogen feeds fibroids. And so if you could somehow, perhaps through diet or exercise, to lower our BMI and our other sources of estrogen, if we can certainly lower those levels, then that can help with managing the current fibroids that you have, decreasing or maintaining the size of those. But if there's a concern that my uterus is growing again, it's probably the development of new fibroids, not a growth of the ones that we've treated.
Thank you. A question is, thank you for this enlightening information. Are we able to access the slides after the meeting? I will say that we did record this session, so we will be distributing the recording to everyone that registered. So you will be able to watch the webinar again. And in addition to the information that was shown on screen, there are links in the chat to both Dr. Lane and Dr. Whitfield's profiles on our physician locator, where you can fill out an inquiry form there, and we'll be sure to connect you with their office to schedule a consultation and get more information. Another comment is just awesome presentation and claps for you both. So thank you.
Thank you.
Ladies, any other questions in the chat, please feel to put them in over the next minute or so. This is your one opportunity to ask as many questions as you would like to these physicians that have graciously donated their time this evening.
And I just want to thank you all for spending your evening time with us to talk about fibroids. I mean, you could have been anywhere tonight. So I appreciate you doing that, because it's so important that we learn about our bodies and we don't totally depend on someone else to tell us what our options are. I think now you're going to approach your gynecologist with a lot more ammunition, if you want to use that word, in terms of what your options are. And it's okay if your doctor doesn't seem to be versed on all of these options, and because there's plenty of OBGYNs in the city that can help you. And I love the Finder feature for Sonata, and they can help you find doctors such as myself and Dr. Whitfield that perform the procedure, no matter where you are, so that you can find someone that can give you kind of that full spectrum of options in regards to your fibroid. So thanks so much for spending time with us.
Absolutely.
Thank you. And I don't think we have any other questions. So thank you both. Oh, wait, 1 second. I spoke too soon. If your fibroids have enlarged your uterus, but you're pretty much asymptomatic, except for some bulk symptoms, left leg swelling, would you recommend removing fibroids for a future pregnancy?
So I would say it really depends. It really depends on the size of that fibroid and its location, because we already know that the uterus is going to grow with the presence of the baby. And while there are, I don't want to say harnesses, but they're belts, they're pregnancy belts and things to decrease the pressure of the uterus itself, the fibroids and the baby off of the lower pelvis, which takes the pressure off the vessels. It really depends on where that fibroid is and its impact currently. You know, as I mentioned before, I have seen patients who, you know, show acute renal insufficiency because the kidneys aren't getting appropriate perfusion. They're not getting adequate blood supply. Definitely the pregnant state can increase your risk of developing blood clots. And then if that is coupled with a big watermelon that's sitting on the main vessel that drains the blood and brings blood back to your heart, you're at an increase of a lower extremity blood clot. So I think we have to factor the entire patient and what the patient is bringing to the table to make the best recommendation on whether that fibroid needs to be removed. How big is that fibroid? Because that fibroid and its impact is going to compound the natural physiological changes that occur in pregnancy, which could make for a complicated pregnancy. And our goal is a healthy outcome for both mama and baby. So I would say it depends.
And
Yeah, I would definitely agree with Dr. Whitfield. And I would also just emphasize that in pregnancy, we have two patients. We have the mom and the baby. And depending on the location of the fibroid, the size of the fibroid, if it's growing, it could actually impact the growth of the baby as well. There's also other risks like preterm labor, placental abruption, depending on if the placenta is implanted over the fibroid. So depending on the size of the fibroid, the location of the fibroid would really all determine whether or not it's worth the risk of cutting into your uterus, removing a fibroid, or is it better to just use a procedure like Sonata, depending on your size of fibroid, to simply try to shrink the fibroid before you become pregnant? That's a wonderful conversation to have with your doctor for sure.
thank you. And one final question is, what is the length of time for the Sonata procedure?
It really will depend on how many fibroids are being treated and how big they are. As Dr. Whitfield mentioned as well, we often will treat one fibroid multiple times. So if you imagine, let's just say you imagine something the size of an orange, and you want to divide that orange into 3 different segments, so that you can always say use the word zap because we're using a radio frequency energy, but you might zap 1/3 and then the middle third and then the right third, and to make sure that you've basically ablated as much of that fibroid as possible, as opposed to just one section of that fibroid. So if you can imagine, if you're spending that time to ablate different sections of that orange, then it's going to take more time depending on how many of those oranges, golf balls, walnuts, whatever it is that you have. It's going to take more time depending on how many you have and the size of them as well. So the procedure varies, but I mean, it could be a couple hours depending on how many. I think if you get to more than a couple hours, then you might start thinking about whether or not that particular fibroid or a certain fibroid is a good candidate for the procedure if it takes that long. It really is not a procedure that you should be in the operating room for like 4 hours and 5 hours. It should not be like that.
Thank you. Dr. Whitfield, you're on mute.
Thank you. The great thing about this procedure is that it is an outpatient procedure. This is not a procedure that's going to require hospitalization for recovery. So while we may be treating a number of fibroids, the goal of the procedure is not to treat every fibroid that we see. We're treating the fibroids that are likely contributing to the symptoms you're having. So as you have seen, I'm sure, on your research of fibroids and myomectomy, a myomectomy is a surgical incision in the uterus to remove that fibroid, and then we close up the defect or the space where that fibroid once consumed. Sometimes you see pictures where they have removed 21, 22, 25 fibroids from, the size of a dime to the size of a grapefruit. Our goal for this procedure is not to go in and treat every fibroid we see, because depending on, the patient's comorbidities, depending on what the end goal is, if the end goal is to treat the fibroids that are contributing to the bulk symptoms or the pain or the bleeding, then our first goal is to go in and treat those. If you're looking for a procedure that you want to address every fibroid that can be identified, this procedure would not be the best for you in terms of Sonata. If you're looking to have procedures that impact, the uterus globally to treat, as many fibroids as you can, one option may be uterine artery embolization, because that is a procedure that is going in with CT guidance or MRI guidance to treat every fibroid that is reasonable to treat, affecting the blood supply to those fibroids. But keep in mind, as long as there's smooth muscle present, none of these procedures prevent the development of future fibroids. We're treating what is present and what is most symptomatic.
And just really quick to add to that, if you are thinking about future pregnancy, we talked about that. I just want to make sure you're clear on this. Even though the uterine fibroid embolization, also referred to as uterine artery embolization, is a procedure to stop the blood flow to the fibroid and shrink the fibroid, the Sonata is about shrinking fibroids through radio frequency energy. Once again, not radiation, but radio frequency energy. If you're thinking about having children in the future, you want the procedure, the Sonata procedure, that's the one that we are finding it's safe for you to still have children after a Sonata or a transcervical fibroid ablation, and not the uterine fibroid embolization. So just want to make sure that you all are clear on that. The Sonata procedure is the one that you want if you're thinking about having children in the future.
Great point of clarification. Thank you, Dr. Lane.
Thank you. And one final question, final, they keep coming in, sorry. Are a hysteroscopic myomectomy and a hysteroscopy the same procedure?
Okay, so hysteroscopy is the procedure just in general to take a camera with this long scope and you're looking inside the uterus. It's kind of like walking into a room and looking around, but you're doing it transcervically, very similar to the Sonata, but it's a long scope looking around, taking biopsies. You can do surgery that way. The hysteroscopic fibroid resection or myomectomy, that just refers to while I'm in there looking around, I'm going to also do some work. I'm going to start removing the fibroid that I'm seeing. So that's the uterine, that's the hysteroscopic fibroid resection or myomectomy. So there's diagnostic, just going in and looking with hysteroscopy, or there's operative where you're actually doing some work, and that's the removal of something, biopsies. Hopefully that clears it up for you.
Thank you. And as we said, there are links in the chat if you would like to schedule a consultation with Dr. Lane or Dr. Whitfield, and you can ask them, any of these questions and more. We're getting a lot of thank yous in the chat to both of you. So thank you very much for sharing all this information and empowering women with the information that they need to know about fibroids and their treatment options this evening. Ladies, we will get a recording of this, so keep your eye out for that. Feel free to share it with anyone that you know. A lot of women out there have fibroids, so information is power, so spread the word to them. And thank you very much for joining us.
Thank you. Thank you, everybody.
Bye-bye.
Thank you. Bye.